Hello, and welcome to this complimentary presentation from Lactation Education Resources. I am Sekeita Lewis-Johnson, and I will be your guide as you begin to prepare for your breastfeeding and lactation journey. So, a little bit about me. I am a retired labor and delivery nurse, a board certified lactation consultant, a board certified nurse practitioner, and a birth doula. After viewing this video, it is my wish that you will be able to determine whether or not you will need any interventions prior to birthing your little one. If so, what are those interventions? If you have concerns or questions, or maybe even unsuccessful past experiences, please share your concerns with your healthcare provider and maybe even seek an appointment with a lactation consultant to determine a lactation plan that is just right for you. It is my wish that you have increased confidence in your ability to feed your baby and that you will be successful in your feeding goals. I also hope that you have a good understanding of latch and positioning to ensure that your baby can have optimal feeds. And lastly, I hope that you are able to determine when to seek assistance from lactation professionals after birth. Let's start with the recommendations. The American Academy of Pediatrics has a policy statement on breastfeeding, and here are some of the important points. It's important to note that the global recommendation for infant feeding is an exclusive human milk diet for the first 6 months of your baby's life. There are major health benefits for both you and your baby. For you, there's a decreased risk of developing breast or ovarian cancer, among other benefits. And for your baby, a decreased risk of sudden infant death syndrome, incidence of childhood cancers, development of allergies, and many others. Skin to skin is highly recommended immediately after birth until the first feeding is accomplished. Continuous rooming in allows you to learn your baby's feeding cues and to feed whenever your baby is hungry without delay. Avoiding commercial infant formula is recommended unless there is a medical indication to do so. And lastly, there's a lot of biased information out there, especially in the world of the internet. However, healthcare providers are held to a standard to give unbiased information so that you can make a fully informed infant feeding decision and prepare accordingly. As I just stated, there is lots of information available about breastfeeding. Please make sure that wherever you get your information, that it is reputable, valid, and true. The internet is endless, so you want to try to avoid websites on breastfeeding, particularly hosted by formula companies or that have banner ads of formula companies. Their information is often suspect with a hidden agenda. So take this time to read and ask lots of questions as you are beginning to prepare for this next phase in your life. Alrighty, let's dig in. Let's talk briefly about breast anatomy. Please know that the breasts are also known as mammary or glandular tissue. Most times I will say breast, but sometimes here or there I do resort to using the more medical terms, and I apologize. I don't want you to be confused. I'm talking still about the breast. If you have never really looked closely at your breast or chest, please take a moment after this slide to do so. You can stop the video if it's appropriate, or you can do it later whenever you can. But look at your anatomy. Look at your nipples. Notice if you see anything concerning that you may want to speak with your healthcare provider about. Is your breast growing? During pregnancy, the breast should grow at least 1 cup size. How about your nipple? Are they flat? Do they protrude outward? Or do they go inward, which is also known as inverted nipples? If you notice that you have inverted nipples, it's important to speak with a lactation consultant before you birth your baby. It's not uncommon for some people to leak during pregnancy, and others do not. This phenomenon has no significance in determining milk production after you birth your baby, so don't be alarmed. Also note that the use of creams or toughening up exercises are not necessary. In saying that, I know there is a cultural variance to many things in birth and breastfeeding. So, by all means, if it doesn't harm you, continue your practices as you see fit. I want to call your attention to the Montgomery glands that are located on the areola. These glands get more prominent during pregnancy. They secrete an oil that kills bacteria on the nipple and areola. The oil that is secreted also smells like amniotic fluid, and your baby is used to that smell. So your baby will be attracted to that familiar scent right after birth. This will help facilitate the first feeding. So don't wash your breast before feedings. Keep the bacteria fighting oil in place so that your baby can smell and your baby knows exactly where to begin the first feed. Inside your breast are clusters of alveoli. These are called the milk producing factories. That's right, milk is made and stored right in the alveoli. There's also a system of ducts that connect the alveoli and lead to the nipple. The ducts are responsible for transporting the milk to the nipple and out to your baby. Think of the ducts like a cluster of grapes. The grapes and the stems are arranged in the same fashion as the alveoli and the ductal system. Remember when I said to check your nipples? Well, here is a visual to assist you with your endeavors. Most nipples are erect or stick out most of the time. Babies usually have an easier time attaching to this type of nipple. Babies can also attach to flat and inverted nipples. However, some babies may need just a little assistance to achieve an effective latch for feeding. Sometimes you really can't tell what type of nipple you have unless you do the pinch test. That means you gently squeeze at the edge of the areola and see what happens to your nipple after you do that. Or you can rub your nipples to stimulate them. This test will give you a more accurate picture of your nipple type. If your nipples retract inwards, then you have inverted nipples. In other words, they remain dimpled inward and do not protrude outward no matter what test you do. If you have either flat or inverted nipples, it's important to contact a lactation consultant to discuss what you can do prenatally to prepare for your journey. Breast shape can also be important. Let your provider or lactation consultant know if you think you may have widely spaced breasts, unusually large nipples, or breasts that have a more concave look rather than rounded and full. Take a look at the pictures and notice the black lines indicating a concave appearance. Breasts that are markedly different in size should also be evaluated by your provider or a lactation consultant. Let's talk about milk. Colostrum is the first milk, and it is present from the 5th month of pregnancy onward. So it is ready to go even if your baby is born a bit early. It is very high in immunities and is very protective to your newborn. This is the milk that your baby will receive the first couple of days of life, after which comes what's called transitional milk. It is the changeover from colostrum to mature milk. This is sometimes the stage that's called your milk coming in. It usually occurs on days 3 to 5 after birth. After a couple of weeks after birth, your mature milk is in, and this is the milk that your baby will drink for the next several months. Mature milk is expressed as 2 types of milk, the foremilk and the hind milk. The foremilk is the milk from the beginning of the feeding, or if you are using a breast pump, the beginning of the pumping session. It is high in carbohydrates and low in fats. This milk contains essential ingredients that your baby will need for brain development. Hind milk is the milk from the end of the feeding or pumping session. It is high in fat and assures that your baby gains adequate weight. You can think of your foremilk like the salad or an appetizer of a meal, and the hind milk as the entree or even the dessert. The baby must stay on the breast or chest, feeding long enough to get both kinds of milk. Therefore, when your baby is feeding, allow them to stay on one side as long as they are feeding. In other words, watch your baby and the quality of the feeding and not the clock. I'll talk more about this later in this presentation. All right, so now let's move forward. You have labored and birthed your baby. So now what? If you've guessed it's time to feed and bond, then you would be totally correct. Let's talk about it. Immediately after birth, hold your baby skin to skin until the first feeding occurs. The first feeding is usually within 1 to 2 hours after birth. Your baby will locate the breast primarily by smell, sight, and feel. So do what comes naturally for you and your baby. Skin to skin have so many benefits. So hold your baby skin to skin as often as you can for the first several months. It's the best remedy to awake a sleepy baby, to calm a crying baby, and the first thing to try for any breastfeeding or chest feeding problems. Dads and partners can do skin to skin also, especially if you've had a cesarean delivery. Dad or your partner can take over for a while. Studies show that babies cry less, stabilize their temperatures, and feed sooner when held by their dads. There are often concerns about bonding when families choose breastfeeding as their feeding choice. Rest assured that skin to skin with dads and partners facilitate bonding. There is also evidence that indicates that fathers experience less anxiety and better role attainment when skin to skin is done with their babies. You will see your baby go through different states of alertness during the day, from crying to deep sleep, especially on the first day. The quiet, alert state is when your baby's eyes are focused and they are blinking and settled. The active alert state is characterized by moving, looking, and making sounds. It is usually during these states that you'll notice feeding cues. That means your baby is showing signs that they are ready to feed. Your baby may begin opening their mouth, turning their head side to side, or try to bring their hand to their mouth, smacking their lips, or even licking their tongue out. Tune in to your baby and learn their cues and offer feedings before crying starts. Crying is a late sign of hunger, and this is the state where it can be challenging to get the most optimal latch and positioning for feeding. Take a look at this baby. This baby is showing us some great feeding cues. At the beginning of your journey, feedings can feel intense. Frequent feedings are important to make sure that your little one is adequately fed and hydrated. Frequent feedings can also help to optimize your milk production for the duration of breastfeeding. Babies should feed at least 8 times in 24 hours, keeping in mind they may feed more. These frequent feedings may make you think something is wrong. Frequent feeding is a normal pattern. Also, your baby may cluster their feedings. That is, they may feed several times in a row and then take a longer break for sleep. This is also normal. Time spent at the breast does not equal milk intake. Remember, babies must be fed through the night for the first several weeks or more. And you can plan for those night feedings by getting a nap during the day and or minimizing visitors during the day. If your baby is sleepy and you are not on track to get 8 feedings, you will have to wake your sleepy baby up. The ultimate goal is to stimulate your baby's senses. You can do this by undressing your baby, massaging their tummy, back, head, or feet, even talking to them. And don't forget about the good old faithful skin to skin. You might even try to manually express the milk onto your baby lips so they may taste it and may think, okay, it's time to wake up for a feeding. So, what's feeding like without a good latch? Let me just tell you, you do not want to know. Let's get into it. There are two styles of attachment for feeding. Baby led latching is allowing the baby to find the breast and self attach. Sometimes this occurs with the first feeding when there has been minimal medical interventions. The breast crawl is one example of this. Mother led latching is when the mom or parent uses techniques to facilitate the attachment. This style works well for feedings during the first few days of life, especially with a sleepy baby, and may require some assistance from hospital staff. Notice the difference in the two styles. In the first picture, mom is passively allowing the baby to find their nutrition. In the other picture, the mom is holding her breast tissue and the baby, along with assistance from staff. To achieve a deep latch, the asymmetrical latch is recommended. There will be a bit more breast tissue from the bottom of the areola than the top. To achieve this latch, you simply aim the nipple at your baby's nose like the top picture. Think about placing his lower lip on the lower edge of your areola. Then watch for baby to give you a wide open mouth, approximately 140 degrees wide, which is really wide. Then attach. This technique will benefit you both. The deeper your baby attaches, the more milk they will be able to effectively remove and the more comfortable you will be. This is a great picture of what attaching should resemble. In this picture, you may notice that the baby's head appears to be tilted back a bit. The nipple has been drawn down from the nose, the bottom chin is touching the areola, and the mouth is wide open. When you are checking for a good latch, make sure that the chin is touching the breast, the nose is free and not blocked. Both lips, the top lip and the bottom lip, are flanged outward. That means rolled outward. Think of a fish, how a fish lips look. Angle of the lips should be wide, really wide, just like the picture that I just showed you. And then also look at this picture. Should be greater than 140 degrees. Also, the majority of the areola should be in the baby's mouth. You should hear no clicking or popping sounds, and there should be no chomping or biting movements. If you need to adjust or improve the latch, try to pull your baby close, especially by the hips. Try not to rush the latch and make sure to wait for that wide open mouth. You can also adjust the latch by tugging gently on your baby's chin to get a wider latch. If the latch is not correct or it hurts, detach your baby and try again. Feeding with a poor latch can cause significant pain and ineffective milk removal, which results in an ineffective feeding. A shallow latch is the opposite of a deep latch. A shallow latch occurs when the baby does not have much of the areola and is sucking at the very tip of the nipple. When this happens, nipple trauma and pain can and does occur. Notice in the pictures, you'll see a flattened nipple and reddened nipple. Some nipples become so sore that even when the latch is optimized, feeding may be painful due to the trauma from an earlier shallow latch. A quick look at your nipple once your baby detaches can give you great information. Look at your nipple immediately after baby finishes feeding. It should be round, not flat, creased, or noticeably red. Now that we've discussed latch, let's talk about positioning. When it comes to positioning, your comfort and baby's body alignment are key elements to getting a good latch. Positional aids are sometimes necessary to achieve comfort. You don't need the fancy pillows that are being advertised. Regular pillows can work just fine and are sometimes better than what is being marketed as breastfeeding pillows. Okay, baby's alignment. Position your baby so that their ear, shoulder, and hip are all aligned. This means that you can draw an imaginary straight line from the tip of the ear to the shoulder and then to the hip. Have your baby face their food, meaning they should be belly to belly with you so that they can get close. And your baby's nose should be aligned right with your nipple, just like the picture. In these pictures of parent-led latching, notice the hand placements. Whenever you hold your baby at the breast or chest for a feeding, hold them at the nape of their neck instead of directly on the back of their head. Sometimes pressing on their heads may cause babies to pull back as if they don't want to breastfeed. So your hand is at the nape of their neck and your thumb and fingers are placed ear to ear for support. The first picture in this example of positions is called the cross cradle hold. As you can see, she is holding the baby across her lap with control of the neck, using one hand and holding her breast tissue with the other hand. Notice the baby's position. The ear, shoulder, and hips appear to be aligned, indicating that this baby is tummy to tummy with mom. The middle picture is called the football hold. The football hold is essentially the same technique as the cross cradle hold. However, the baby is tucked in at your side, like in this picture. Notice the pillow underneath the baby, which allows for additional support. In the last picture, you see the cradle hold, which is pretty self-explanatory in how we typically hold our babies. Again, notice the baby's alignment and also notice the additional pillow for support. Side lying is great for getting a little rest and relaxation while your baby feeds, especially during night feedings. Roll on your side and position your baby on their side facing you. You can place your hand or rolled blankets at your baby's back and at your back to keep you both in position as you relax. Also, a pillow between your legs may help with comfort. We've talked about hand placement on your baby. Let's talk about hand placement on your mammary tissue. If and when you need to use your hands to assist with positioning, it's important that they are away from the areola. Place your fingers below, supporting your whole breast, and make sure your fingers are behind the edge of the areola. You want your baby to take most of the areola in their mouth, and they may not be able to do this if your fingers are in the way. Look at these pictures. They are great examples of how your hands should be. Remember, positioning matters because it minimizes and prevents nipple pain and trauma and helps to optimize your baby's feedings. One of the most common breastfeeding questions that I hear is, how do I know if my baby is drinking my milk or getting something? You will know if your baby is removing milk by assessing and listening for milk transfer. The sound is very faint and quiet, so it involves actively listening for it. It will be helpful to turn down the TV, mute conversations, and really pay attention when your baby is eating, especially during the first week. You are listening to hear sounds like k, k, k. You'll notice these same sounds on the YouTube video that's on this slide. You should also notice that your baby sucks in a rhythmic fashion with wide jaw movements. Babies will suck a few times, breathe, and swallow. So it may be like suck, 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 suck. Pause for breath, swallow, suck, 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 suck. Pause for breath, swallow. Notice I am like pausing between the suck, right? That's a rhythmic type of fashion. If you ever have questions, please make sure you call someone to your bedside so that they can help you assess whether or not your baby is transferring milk. Another common question is, how long should my baby feed? And my answer is, as long as your baby is removing milk, keep feeding. Keep your baby stimulated during the feeding and watch your baby for signs of satisfaction and not the clock. Feedings are usually no longer than 30 minutes. How do you know when the feed is over? Let's take a look at this example. Notice in the first picture that the baby's eyes are open and their fist is tight. This first picture is usually how babies look at the beginning of a feeding. During the feeding, notice the baby starts to relax a bit. Notice the eyes are closed and the hands have become a little bit more relaxed. Also notice how the baby is not as widely attached in the first picture. And finally, the baby slides off the nipple and the feeding appears to be over, at least on that side. When this happens, attempt to burp your baby. Some babies don't burp and some babies do. So don't spend a lot of time on burping. Then offer the other side. If your baby takes the other side, fine. If not, sometimes that's fine too. Oftentimes, babies act like their feeding is over, and then they wake up 5 to 10 minutes wanting more. Sometimes this is a typical pattern. Don't let it rattle you. Offer the other breast again. Likely, your baby will feed for a few more minutes before falling fast asleep. When a feeding has concluded on one side and the baby does not spontaneously break the suction, you can break the latch with your finger simply by slipping your finger between your baby's gums to release it. Another method that may release the latch is to gently pull down on the chin. Breaking the suction can also be helpful if you need to detach your baby and then relatch for a deeper latch. Now, on to the last, most frequently asked question in breastfeeding and human milk feeding land. How do I know that my baby is getting enough? The best way to know if your baby is getting enough milk is to watch his diapers. I always tell my clients, what goes in must come out. The first stools are thick, tarry, and black. This stool is known as meconium. Meconium will change as your baby eats more, and the stools will gradually turn into a bright yellow color, and sometimes it looks like it has curds. At about 4 days of life, your baby should have had at least 4 to 6 wet diapers and at least 3 yellowish stools per day going forward. Your hospital or birthing center may give you a chart to keep track of the feedings and soiled diapers. If not, good old fashioned paper and pen is more than adequate. Also, there are apps available that can help you keep track of all the feedings, all the wet diapers, and all the stools. You will be happy to know that you can eat whatever you like. Whatever you like, right? So try not to limit your diet unless you notice that you or your baby have problems with a particular food. Remember to drink to thirst, ensuring at least 8 glasses of water daily. And if you have certain allergies in your family, please plan to discuss this with your pediatrician at the baby's first visit. There are special circumstances that I want to bring to your attention. If you are a vegetarian, vegan, or have a history of gastric bypass surgery, please be sure to include a B12 supplement in your diet, especially during lactation. If any of these scenarios apply to you, please seek a prenatal lactation consultation before you birth your baby. Additionally, if you are not eating dairy products, please make sure that you are getting enough calcium from food or supplements. There are many critics that like to weigh in on how we feed our babies. The debates about certain things are endless. When it comes to providing human milk for your baby, just know that it is not an all or nothing decision. Some people, for their own reasons, consciously choose to pump and provide human milk. And to this I say, pumping is breastfeeding. Of course, there are advantages to direct feeding. For example, the biofeedback loop that happens when babies nurse at the breast. This happens when babies start to get ill or they are exposed to illnesses, during which time, during feedings, their saliva sends signals to the nursing parent's body to create antibodies for their protection. This phenomenon is truly fascinating. However, with that being said, there are many reasons why people choose to only pump and provide their milk. And to this I say, kudos to you because that is truly a labor of love. Critically important to everything I've said thus far is building your team of support. Discuss your feeding plans with your loved ones. Tell them how you want them to support you and try to be as specific as you can. Ask them to take classes with you or even view this video. Let your healthcare provider know your feeding plans and discuss any concerns you may have. And lastly, check your local area for lactation professionals and or board certified lactation consultants before you deliver. Now let's see if you can guess this fun fact. True or false? A newborn's stomach is the size of a golf ball. I'll give you a few seconds to think of your answer. If you said false, you are absolutely correct. A newborn's stomach starts off very small. It's literally the size of a cherry. On the first day of life, the newborn stomach capacity is only about 5 to 7 milliliters. This means that the newborn stomach is designed for small feedings and can hold just a little bit over a teaspoon. Okay, here's the next one. True or false? Breast milk should be measured to make sure that the infant is getting enough. I know you said false because I just went over this. Remember to feed at least 8 times in 24 hours. Remember the catchphrase, 8 or more in 24. Remember to listen for audible swallow and count those diapers. I hope this presentation has given you a start to prepare for your infant feeding journey. Please be aware that the information provided in this presentation is intended solely for general, educational, and informational purposes. It is neither intended nor implied to be a substitute for professional medical advice. Always seek the advice of your physician for any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you have received in this program. On behalf of Lactation Education Resources, thank you for watching this presentation, and we wish you all the best.